Hello, Dr. Raymer here. Today we're talking about the cranial meninges. We'll talk about how they compartmentalize the brain inside the skull, and by extension, how they create anatomical compartments of bleeding when that occurs inside the skull. So first we'll talk about the anatomy of the cranial meninges and their relationships to one another and to the skull and the brain. And then we'll talk about brain hemorrhage. So the large, very soft brain is compartmentalized and surrounded by protective features. And one of these features, of course, is the skull. Now, as we'll see, the thick, bony, unyielding skull both protects the brain and creates a compartment within which pressure can rise, ultimately damaging the brain. So the unyielding nature of the skull is a double-edged sword when it comes to brain. On the inner surface, here in the skull base, ridges divide the base into different compartments, or fossae. And the anterior fossa, sort of coated in green, contains the frontal lobe. That's up here. The middle fossa contains the inferior portion of the temporal lobe, colored in red. And the posterior fossa, of course, contains the cerebellum and the brainstem. And that's all shown in blue. So the fossae and the skull base and the corresponding bits of brain that they contain. The anterior fossa, you can see, is separated from the middle fossa by the lesser wing of the sphenoid. That's the bony ridge there. And the petrous ridge of the temporal bone separates the middle and posterior fossae. Now, in this cutaway superior view of the cadaveric head, we can see all of the layers that lead us down to brain. So for working our way from superficial at the scalp on the left here, we have the epicranial aponeurosis, that tough, fibrous connective sheath that links musculature anteriorly and posteriorly and sits over the skull. And then there's a loose connective tissue layer and periosteum that lies over the bony skull itself. Deep to the bony skull, the thick dura mater and the relatively thin and delicate arachnoid. And you can't really see pia here. It's very difficult to separate the arachnoid and the pia in dissection. They're very thin, delicate layers. So what you're looking at after the arachnoid's removed in this dissection is the surface of the cerebral cortex. And that's how we normally see brains in the lab, is all of the meninges have been removed and we're looking at cortex. And this is the type of coronal schematic we often see, showing the layers we saw in the previous slide represented in a schematic. And so we have the layers of tissue, skin to periosteum or pericranium that lie superficial to the skull, and then the cranial meninges that lie deep to the skull. We can see that the dura mater consists of two layers, a periosteal layer and a meningeal layer. The periosteal layer is, of course, superficial against the skull, and that these layers are tightly opposed in most places over the cortex, except where they come apart to contain venous sinuses. And here we're in a coronal section on the midline looking at the sagittal sinus. You can see that this inner layer dips into the brain here, and that forms one of the cranial folds. So it actually forms the fold that lies on the mid-sagittal plane. And we'll talk about that in just a moment. Of course, deep to the dura, we have the arachnoid mater and the dura mater. And you can see that the arachnoid space is represented here. It contains not only arachnoid trabecula, but also vasculature supplying the brain and the cerebrospinal fluid. So here's another cadaveric dissection, and it's nice to bounce back and forth between a real dissection and a schematic so you can remember what things actually look like. And so here is a coronal section of that sagittal sinus on the schematic. And here in a dissection, because we're right on the mid-sagittal plane, you can actually see the superior sagittal sinus between the periosteal and meningeal dural layers. You can also see that in this dissection how the arachnoid is overlying all of the cerebral vasculature that supplies the cortex. And you can see that because it's sort of cloudy, semi-translucent over the surface of the brain. Now finally, this is a scanning electron micrograph of the cranial meninges, happens to be in a dog, but I like to show this, the SEM, the scanning electron micrograph, so people really get an appreciation of how thick and tough the dura is. So that's the thickness of the dura mater relative to the arachnoid and the little delicate pia. And so you can see how big and thick the dura is. You can also, in this image, see that there is a space that should not be there. So this space is an artifact of tissue processing. This is not a real space. So the space between the dura and the arachnoid in this section, we would describe in vivo as a potential space, whereas the subarachnoid space, of course, is a physiological or a real space. So make sure you're making that distinction. This is one of the blood vessels supplying the cerebral cortex, so that big vessel, and you can see how it resides within the subarachnoid space. So as we said, the dura consists of two tough fibrous layers, an outer periosteal layer adherent to the inner surface of the skull, and an inner meningeal layer. And they're tightly opposed, except where the inner layer descends to form those dural folds. And this mainly occurs in two places. Technically, there are 4 named anatomical dural folds. In terms of what's important clinically, especially for brain hemorrhage, there's really 2. So the first is the false cerebri, it's shown here in blue, and it's in the mid-sagittal plane, and it separates the left and right hemispheres. The second is the tentorium cerebelli, shown here in green. This is that tent-like, aptly named, sheet of dura that covers the upper surface of the cerebellum, tentorium as in roof, and it lies nearly in the transverse plane. So in this cadaveric dissection, you can see the false cerebri popped out from between the 2 cerebral hemispheres. The dura is all reflected back here, so what you're looking at is the arachnoid overlying the surface of the cortex. And what you can appreciate with the falx, especially when you see it like this, is that there's a substantial space underneath it. And that's important for brain hemorrhaging. Tissue from the brain can shift laterally deep to the false cerebri. Now, in addition to that space underneath the false cerebri, there's another clinical space associated with the cranial meninges that's really important. And this is the space in the middle of the tentorium cerebelli through which the brainstem passes. So here we're looking down on the whole thing. We're in a superior view. The false cerebri has been reflected again posteriorly out of the way, and you're looking down on the pons because the midbrain in this dissection has been removed. You can see a bit of the cerebellum at the back, the wrinkled surface of the cerebellum, and it's this space in the tentorium cerebelli that's called the tentorial notch or the tentorial incisure, and it's clinically important. Now, this schematic of sort of a superolateral view of the midbrain, which hasn't been removed this time, it's here within the tentorial notch. So here's the edge of the tentorial notch in the green tentorium cerebelli. This is an important schematic because it shows you what's at the level of the midbrain and the notch. Remember, the dura is relatively unyielding. So whatever's present at the edge of these spaces has a potential to be compressed when the brain moves within the space. So let's look and see what's here that's clinically important. You're looking at the cut surface of the midbrain, the superior surface of the midbrain. On the anterior or ventral portion of that are the cerebral peduncles. So here are the cerebral peduncles anteriorly. We also have the ocular motor nerve that exits at this point, obviously bilaterally. And so the ocular motor nerve is exiting right here. And finally, but also important, we have the posterior cerebral arteries, which are arising at this point from the basilar artery on the anterior surface of the brainstem. So three things that are right at the edge, sort of the anterior or ventral edge of the midbrain, at the level of the tentorial incisor or tentorial notch, the cerebral peduncle, the ocular motor nerve, and the posterior cerebral artery. So this is a CT at the level of the notch. You can see the sort of reference point level right here. And you can see, always looks kind of like a butterfly, the midbrain here, the wings of the midbrain. And the very anterior margin of that is where the cerebral peduncles reside. And just as a reminder, here are the cerebral peduncles. So this time you're looking anteriorly at a fresh sort of dissection, I suppose a fixed dissection of the brain. So here they are, there, and there. And that, of course, is connecting the cerebrum to the brainstem. So in terms of clinically relevant spaces created by the meninges and the skull, we've talked about two: the space under the false cerebri and the space opening within the tentorium cerebellum. The third clinically important space is the opening in the skull. It's at the bottom of the skull. Of course, it's the foramen magnum. And at this point is the junction of the spinal cord and the medulla. So here is a CT at that level. Here's your reference level for that CT. And right here is the foramen magnum. And so if we look at that on CT, what you're going to see anteriorly are the large air-filled maxillary sinuses. That's why they're so hypodense, provided you don't have a sinus infection. And here is the opening of the foramen magnum. And you don't need to pick up specific structures within that, but this round opening, of course, at the very base of the skull is the third really clinically important space when we start to talk about brain shift and hemorrhage. Now, one bit of terminology you'll hear when you talk about brain hemorrhage and the meninges is supratentorial and infratentorial. And this just is two compartments on each side of the tentorium cerebelli within the cranial vault. And so they're indicated here in a really simple way. So there's the tentorium cerebelli in red, and essentially it's the whole cerebrum that's supratentorial, and the cerebellum that's infratentorial within the posterior fossa of the skull. If you're ever wondering why this bird is here, it's because the sort of edges of the tentorium cerebelli are often compared to the wings of a bird in flight. That's why there's often a bird with this diagram. And so when I said the tentorium cerebelli is approximately in the transverse plane, it's because it's, of course, not perfectly transverse. It's a bit swoopy, like the wings of a bird. So here's just a few images in different planes looking at those compartments. On this compartment, in this image, you can see the false cerebri right on the mid-sagittal plane. So we know are relatively dorsal because the false is continuous. And you can see the right and left cerebral hemispheres obviously occupying the supratentorial compartment. On this coronal view, now we can see both dural inflections. So this is a really nice view. Here is the superior sagittal sinus. Here's the false cerebri descending on the midline. Here is the tentorium cerebelli bilaterally. And obviously you see the supratentorial compartment and the infratentorial compartment nicely shown in this image. And finally, in sagittal view, I'll just edit this a bit so you're not really seeing both dural inflections, because of course if we were right on the midline, we'd be cutting directly through the mid-sagittal false cerebri, but you can see the tentorium cerebelli here and showing you the demarcation of the two compartments. Now, as I've already said, these meninges within the skull create two types of spaces. They create normal spaces that are physiological, namely one normal space, which is the subarachnoid space, and also potential spaces, which are essentially created by bleeding. And so this is the important table on this slide right here the epidural space and the subdural space, which are potential, and the subarachnoid space, which is a real or physiological space. Now, all three of these spaces contain vessels, different vessels, and those vessels create characteristic hemorrhage in response to damage. So the first space I want to talk about in relation to hemorrhage is the epidural space. And the epidural space, what's important about it is that it contains the vessels that supply the dura. And these vessels arise from the external carotid artery. So the vessels that supply the cerebral cortex arise from the internal carotid. Vessels that supply the dura arise from the external carotid. This diagram shows a really important point of vulnerability. So we have the middle meningeal artery, which is a major artery arising from the external carotid that travels between the dura and the skull and supplies the dura. And those meningeal arteries are the things that create these arterial patterns, these depressions on the inner surface of the skull. The middle meningeal artery happens to travel immediately deep to the terion. So terion, like pterodactyl, the juncture between many bones of the skull, overlies, it's thin, it's a bony juncture, and it happens to overlie the middle meningeal artery. And this creates a point of vulnerability to impact on the lateral side of the skull at the point of that terion, and this is often the cause of an epidural hematoma. And so the schematic on this slide sort of reiterates those points. And you can see here in a cutaway, this is where the middle meningeal artery enters the skull. It enters through the foramen spinosum and travels in the epidural space between the dura and the skull. And so here's the entry point of that middle meningeal artery. So epidural or extradural hematomas, abbreviated EDH, typically arise from damage to meningeal arteries. And what they are is an accumulation of blood immediately adjacent to the skull. And it tends to look like a lens. So it punches into the brain, a biconvex mass on CT. And the reason it looks like this is because it's constrained by the skull sutures. So bleeding can't ooze along the inner surface of the skull because in the epidural space, which is potential, created by the blood, the dura is tightly fused to the skull sutures. So that constrains the bleeding and it punches out as a lens, sort of convex shape, into the brain. Symptomatically, epidural hematoma often presents with what's called a lucid interval or a lucid period. So there's a head injury. It's typically a notable head injury. People know they've had this. And then people will say, oh, I'm okay. And there's a delay before neurological symptoms arise, often severe symptoms. So that's a characteristic of this hemorrhage. Now, in order to understand what causes neurological symptoms in response to bleeding in the brain, we have to take a step back and talk about something called mass effect. So mass effect is any distortion of normal brain geometry due to something occupying mass in the brain. So the brain is a bony, unyielding space. It contains soft tissue, fluid, and blood. And none of those are compressible, right? So what happens when there's a mass in that space is it is going to shift those things around, and they are going to travel through one of those three clinically relevant openings we talked about: the space under the false cerebri, the tentorium cerebelli, which the tentorial notch in the tentorium cerebelli, or ultimately the foramen magnum. And so the shift, just the distortion, is called mass effect. And we're talking about it here in the context of hemorrhage, but anything that occupies space that's not supposed to be there constitutes a mass. So hemorrhage, but also a tumor or an abscess or edema, which is the accumulation of fluid, or hydrocephalus, which is accumulation of CSF within a ventricle. All of those are masses in the brain, and all can cause mass effect. So mass effect is the phenomenon that results from a mass. Now, intracranial masses can cause symptoms and signs via multiple mechanisms. So the first, if we think about this epidural hematoma right here, you can think of it as a compressing brain that's immediately adjacent to it. So maybe the first symptoms might be first neurological symptoms might result from that direct effect of the mass locally. However, at the presence of a mass itself, it takes up space in the brain, and that increases intracranial pressure. So the symptoms might be nonspecific, resulting from compression somewhere else due to an increase in intracranial pressure, or ICP. And finally, you get a displacement of structures within the brain. So the structures are under such pressure that they shift from one compartment to another. And the hemorrhage is the bleeding, the herniation is the shift. So two separate words, hemorrhage for bleeding, herniation is the shift. Mass effect is any distortion, and herniation describes specific shifts. So that we get all the terminology of this straight. So here we have an example of mass effect mediated by an epidural hematoma. You can see two images. On the left is a CT that's set for bony imaging, or looking at bones selectively, and you can see a fracture in the temporal bone. So this is a small child, case results here, who hit her head in a car crash. And she's got a fracture in her right temporal bone, and when the CT is set to soft tissue, you can see a corresponding epidural hematoma with that lens shape that's hyperdense on CT and ipsilateral and deep to the site of temporal bone fracture. So absolutely classic epidural hematoma resulting from bleeding in the middle meningeal artery within the epidural space. You can also see mass effect. So mass effect, again, is the geometric distortion of the brain. And here you can see it on this CT because the ventricles are compressed. So if you compare the normal side of the lateral ventricles to the ipsilateral side, you can see that the brain is shifting away from the epidural hematoma. And that compression is mass effect. So this graph helps us understand what's happening with an epidural hematoma and why there's this lucid interval often followed by a precipitous decline. And it has to do with the brain and body's ability to compensate for the presence of a mass for a short time. So the graph here shows intracranial mass volume on the x-axis. And of course, as arterial bleeding proceeds, that volume is increasing along the x-axis. It also shows intracranial pressure, so the pressure within the skull or the intracranial vault, and it's increasing along Y. And here in this coronal schematic, we can see that we've got, in the normal case, at equilibrium, without the presence of a hematoma or another mass, nice full arterial cerebral vessels full of arterial blood. We've got the ventricles that are of normal size full of CSF, and the brain parenchyma or soft tissue looks normal. The geometry or anatomy is normal. Everything's in the place we expect it to be. When there's something like an epidural hematoma, for a period, the brain and the body can compensate for the presence of this mass. And it compensates largely by reducing blood flow to the brain. So the perfusion of the brain is cerebral perfusion pressure, CPP, and it's a product of mean arterial pressure minus intracranial pressure. So that means that as long as intracranial pressure doesn't get too high, mean arterial systemic pressure can overcome it and continue to perfuse the brain. But you can see that perfusion will be reduced as intracranial pressure increases. And that's in fact what you're seeing in this schematic. So it may be clear, but the vessels are smaller, right? Smaller in diameter. There's less blood flow to the brain. The vessels and the ventricles ipsilateral to the mass are compressed a little bit, but again, the brain's still compensating. Blood flow still getting everywhere it needs to in the brain. So there's been a head injury, the person feels okay. And this period of compensation is the lucid interval. That's what corresponds to the lucid interval. Now, in the case of an epidural hematoma, which is arterial bleeding and happens fairly quickly over hours, that we progress from compensation to decompensation, or a failure for the body and brain to compensate for the presence of this mass. So what's happening here? So there's a large increase in intracranial pressure. There is compression of the vessels, so we lose cerebral perfusion. The ventricles, you can see, are constricted as well, so we definitely, mass effect is present in both. But what starts to happen here, when the brain can no longer compensate, we start to develop herniations. And that means bits of brain are heading for the exits that are available. They're literally being squished out of the fixed volume of the cranial vault. So here are the herniation syndromes. There tend to be 4, and they're described by their anatomical result. That's what they're named for. And they also produce characteristic symptoms and signs. They often are a progression in severity. So you don't need to have 1, 2, 3, and 4, but that can happen in terms of a progression. And just a reminder that can be produced by herniations can result from any mass, not only an epidural hematoma. The epidural hematoma tends to produce the fastest type of herniation, or a very fast sort of type of herniation, and somewhat predictable as it grows. And so that's why we're using it as the example. So there's 4. The first is a subfulcine herniation, and that's, if I can find my pen, the movement of tissue laterally, and it might be more accurate to say like this because it's dipping under the false cerebri. The second is a central herniation. That describes the downward movement of the brain, so compression of brain structures inferiorly toward the brainstem. The third has to do with the tentorial notch, which I'll draw in as being about right there. And this is a transtentorial herniation. The most common kind is an uncal transtentorial herniation. That's UNCAL, not UNCLE. Not your uncle. The uncus is the medial portion of the temporal lobe, and it is the first often to bloop, sneak through under high pressure, that opening in the tentorium cerebelli. And the fourth and final sort of type of herniation is out the foramen magnum, so exiting that bony opening in the base of the skull, and it's quite often a tonsillar herniation, in which the tonsil of the cerebellum is the first brain structure to exit out the base of the skull. Good, and that's just represented again here. So a subfulcine herniation, we just put the hematoma on the opposite side, is the scooting of brain tissue deep to the false cerebri. A central herniation is a downward pressure-mediated herniation toward the brainstem, still generally within the supratentorial compartment. The uncal herniation breaches into the infratentorial compartment, not apartment, typically led by the uncus of the temporal lobe. And finally, the tonsillar herniation is the stereotypical type of herniation out the foramen magnum. And this is the tonsil of the cerebellum here, in sort of a medial and an anterior view. So it's the uncus and the tonsil just happen to be the leading anatomical structures in these 2 types of herniation. So the first type of herniation, and typically the least clinically severe, although it can have clinical consequences, is a subfulcine herniation. And again, this is a unilateral mass causing brain structures to herniate from one side of the false to the other. Often there's no clinical signs of a subfalcine herniation, so you could see it on imaging before there's any clinical presentation in front of you. However, it can compress or occlude one or both of the anterior cerebral arteries. And if those are compressed, then you have an ischemic infarct in ACA territory. And you can see that on this cadaveric dissection. So here we can see how much space there is, first of all, under the false cerebri. There it is. And you can see that the false cerebri is immediately is on the mid-sagittal line, obviously, and the left and right ACA are immediately parasagittal to it. So here's the anterior cerebral artery right here, and you can imagine that if brain tissue gets dragged under the false, it will compress, it can compress, doesn't always, one or both ACA. So while subfalcine herniation is often reversible, once we progress to central and other types of herniation, we're in really serious clinical territory. So central herniation is a general term for central inferior displacement toward and of the brainstem. So it's just sort of general downward force in the brain. People really debate about these definitions. This is the definition we'll use. Mild central herniation, sort of prior to evolution to the other types, can cause traction on the abducens nerve, and so that can produce a lateral rectus palsy. And the reason for this is just that the abducens nerve takes a really long course from the brainstem to the eye muscles, to the lateral rectus, and so the long course of this nerve, it is just vulnerable to traction force that's exerted downward, and that's why it's an early symptom or sign of mild central herniation. Severe central herniation can progress all the way to this scenario. So you can get a progression 2, 3, 4 here. If there's severe downward pressure, the ultimate place for brain tissue to exit to relieve the pressure is the foramen magnum. And so this is called coning. This is herniation of the tonsils and compression of the medulla, which, as you can imagine, results in cardio and respiratory arrest and death. So this is a very serious clinical situation, and you can have everything in a central herniation from sort of a very mild, nearly asymptomatic problem, like a unilateral lateral rectus palsy, all the way for progression to coning and coma and death. Now, the third instance is sort of breaching the tentorial notch or the tentorial incisure. And the nomenclature here is also a little confusing. Some people call it an uncle herniation. Really, it's a transtentorial or tentorial herniation, which is just herniation through inferiorly through the tentorial notch. So this herniation is typically indicated by a clinical triad. And the triad is 3 symptoms. It's a blown pupil, hemiplegia, and coma. So those are the symptoms of the transtentorial triad. When we looked at that slide that showed you the contents of the structures immediately adjacent to the edge of the tentorial notch, you get an idea of why these symptoms arise. So first, compression of the oculomotor nerve. It's usually ipsilateral to the lesion. You can see on this case it would be on this side, so the patient's left, our right, ipsilateral to the epidural hematoma. Not always the case, but typically the case. The first sign is a dilated, unresponsive pupil or a blown pupil on that side, and that's due to oculomotor nerve compression. The second consequence of a transtentorial herniation is often hemiplegia. And hemiplegia is produced by compression of the cerebral peduncles against the transtentorial notch. So remember that the dura is not yielding, right? It's not bone, but it's still a rigid thing for brain structures to get compressed against. So this is what happens here. And so the hemiplegia results from cerebral peduncle damage. This is less predictable in terms of laterality. I'll show you what I mean by that in a second. The final sort of indicator is coma, and this is produced by direct compression of nuclei in the midbrain, called the reticular formation. So this diffuse collection of nuclei that are critical for consciousness. And the compression of those at the level of the tentorial notch results in coma. Finally, sometimes, as we saw, you can be compression of one or both PCA arteries at the edge of the notch, and so that produces an infarct in PCA territory. And so this is just that reminder of what structures are visible or present at the level of that notch. We saw this diagram earlier showing the ocular motor nerves, the posterior cerebral arteries, and the cerebral peduncles, the anterior midbrain. Here are those reticular formation nuclei. So just a reminder of where they are at the level of the notch. And if you were to superimpose the level of the notch here, you're above the pons. So you're right sort of about there, give or take, in the midbrain. And that, of course, means your rostral to the level of the pyramidal decussation. So think about that in terms of the cerebral peduncles. And of course, the fourth type of herniation, this is that tonsillar herniation. And it's named tonsillar because the tonsils typically lead the charge here, but it's pressure and extrusion of brain contents through the foramen magnum, colloquially described as coning. Of note, when this occurs in development rather than acutely, it's described as a Chiari malformation, and that's relatively common. So you might know someone who's born with a Chiari malformation. Because that was a gradual developmental event, there are some consequences of Chiari malformation, but many people do just fine. They developed that way. But when that happens acutely, of course, the brain can't compensate. The medulla is compressed and typically leads to respiratory arrest, blood pressure instability, and death as those critical circuits within the medulla are disrupted. So here we've got a little sandwich cross-section that shows you some things. We've talked about this epidural space, and that's typically created by arterial bleeding. The subdural space is another potential space, and it typically results from venous bleeding, from tearing in a vein as it crosses the arachnoid to enter a dural sinus. So let's look at that just for a second. So we know in the subarachnoid space, cerebral arteries and cerebral veins, and those veins empty into the dural venous sinuses. So that's where the venous blood, I know I'm drawing it in red, which is confusing, the venous blood ultimately ends up when the brain is drained. And it's the traveling of those veins through the dura that can create this potential for a subdural hematoma. So this is again shown here. What we're talking about is this bridging vein. So it's rupture of these bridging veins that arise from the main veins draining the cerebral cortex. So main veins in the arachnoid space, bridging veins traversing the meningeal dura. Now, when those veins that traverse the meningeal dura are damaged, they typically produce a subdural hematoma. So a hematoma of venous blood that accumulates between the meningeal dura and the arachnoid. It looks quite a bit different. So it looks like a long, thin crescent that spans further in the skull. And that's because blood can spread easily between the dura and the arachnoid. So we're no longer constrained by sutures of the skull, and that's what causes it to spread out along the skull surface. There's two types of subdural hematoma, obviously, acute and chronic, and they look different on CT. So here we're looking at a chronic subdural hematoma, and this is a common situation in older patients. So as we age, our brain atrophies, another depressing consequence of aging, And this atrophy allows the brain to move more within the cranial vault. And that means those little delicate bridging brains are more susceptible to shear injury. Now, unlike an epidural hematoma, which is typically associated with a notable head injury, you can get a subdural hematoma with minimal or no history of trauma. Sometimes these little bridging veins just burst. And this bleed, again unlike an epi, collects slowly over a period of weeks to months. So the brain does a good job of compensating, right? That means that the symptoms tend to be slow onset and vague. And they're things like a headache, mild cognitive impairment, and unsteady gait. So this chronic subdural hematoma appears dark or hypodense on CT. And so this shows on CT how the appearance of subdural hematoma changes over time from acute to chronic, passing in this direction. So in the acute, if you catch it acutely, acute subdural hematomas will also be hyperdense. And so you can see the hematoma here spreading along the inner surface of the skull, and it's hyperdense relative to the brain tissue around it. You can also see there's a mass effect resulting. I can see that the lateral ventricle is compressed. Quite often you don't see people in the acute phase with subdural hematoma because it takes so long for their symptoms to develop with this slow bleed. If the bleeding stops, there's an isodense phase where you can't really tell hematoma from brain. And that's because the blood is clotted, it's now liquefying, and if you happen to catch it, this would be an isodense phase. But typically, people with subdural hematoma present when it's relatively chronic. So this bleeding's been going on for quite a long time. Here's a large subdural hematoma. It's hypodense to the brain tissue around it. And you can see it's a subdural hematoma because it's crescent in shape and it spreads over such a huge portion of the skull. So it's not constrained by skull sutures. And this is just a little interesting clinical illustration of how hematoma density changes over time. So this is called the hematocrit effect. And that's if a patient's got an active subdural bleed, denser blood settles to the bottom, so the patient's lying on their back. So this person has a right side actively bleeding subdural hematoma, where you get some chronic space or fluid or blood at the top and more dense new blood at the bottom because they're lying on their back, presumably in a hospital bed. Now, this is an interesting case from the book. I just think this case is quite interesting. I'd love to know the backstory. So here we're looking at a somewhat chronic subdural hematoma. And that's what the asterisks show. We know it's a little bit chronic because it's hypodense relative to the surrounding brain tissue. And it's crescent-shaped and spreads over a large portion of the skull. We can see some mass effect. So the ipsilateral lateral ventricle is compressed. The brain is shifting this way. And the story behind this, just to show you that it doesn't necessarily need to be a really traumatic head injury, is a 66-year-old man whose headaches developed gradually after he rode this roller coaster. And he rode it 11 times until his headaches became so severe he was unable to continue. So I'm not sure whether he was on a dare or trying to keep up with a grandchild or whatever, but I just think it's an interesting backstory. You can see his hematoma was surgically removed and the brain symmetry was restored. So his brain returned to normal, lateral ventricles symmetrical on both sides. And you can see this is just a benign finding on CT. Remember that there's some calcifications within the ventricles. So that's a normal finding. What you're looking for is brain symmetry, and that was restored in this person, this roller coaster fan, after surgical removal of the hematoma. Now, earlier I mentioned that the compression of the cerebral peduncles isn't necessarily predictable in terms of laterality. So it's not necessarily predictable or ipsilateral to the site of a mass. And this is a case of a chronic subdural hematoma. Now, don't be confused. These are MRI images. So this chronic hematoma happens to appear bright on this MRI. We can tell it's subdural though, because it's spread over such a large extent of the skull, almost the whole left side of the skull in this patient. So this is a subdural hematoma. It resulted in mass effect and herniation. So showing you that even subdural hematomas, not just epidural hematomas, are sufficient to produce herniation. This caused a shift and compressed the cerebral peduncle right here. You can see it's deformed. So it compressed the right cerebral peduncle by squishing it against the tentorium cerebelli. And so here you can see the deformed peduncle, and here, after surgical removal of the mass, the shape is restored. And so you can imagine what the deficit would be as a result of the right cerebral peduncle compression. Of course, it's left-sided weakness. Now, the subarachnoid hemorrhage is different. It's often abbreviated as AH. This occurs in a physiological space, the CSF-filled space between the arachnoid and the pia, and that space contains the major cerebral arteries. So you can have a subarachnoid hemorrhage from traumatic damage, but can also be non-traumatic or spontaneous via rupture of one of the major cerebral arteries. Now, unlike an EDH or an SDH, in an SAH, the blood is not contained. So it flows freely over the brain, following the contours of the pia. And that's what you see on imaging, is this diffuse bleeding in no specific shape, really, or visible compartment that you can see on imaging. It isn't a compartment, the subarachnoid space, but it's flowing freely all over the brain. The clinical sort of normal clinical presentation is headache, often described as a thunderclap headache or worst headache I've ever had in my life. And then you can also have a whole range of neurological deficits that depend on the extent and location of the bleeding. Because it's arterial bleeding that's not in a contained space, there are huge rates of mortality of subarachnoid hemorrhage. So about 25% of all patients die in the immediate aftermath. They never get treated. And the overall mortality of a subarachnoid hemorrhage is in the range of about 50%. Now, as we just saw, you can see a subarachnoid hemorrhage on imaging, typically. However, if someone has this horrible thunderclap headache, a lumbar puncture can be used to rule out subarachnoid hemorrhage that isn't immediately apparent on imaging. So a lumbar puncture, of course, is a sampling of CSF collected from the subarachnoid space. And so you can use it to test for a number of things. Meningitis is one. It's used to test for inflammation of the meninges, to test for the presence of things like white blood cells. You can also use it to test for the presence of blood, and blood that was present in the cerebrospinal fluid collected via lumbar puncture would be indicative of some sort of bleed in the subarachnoid space, like a subarachnoid hemorrhage. Now, aside from trauma, the most common cause of subarachnoid hemorrhage, or a spontaneous subarachnoid hemorrhage, is rupture of an aneurysm. So remember, an aneurysm is an enlargement or weakness in an arterial wall, and a saccular or berry-like aneurysm is a round outpouching. Now, in the cerebral vasculature, these typically occur near arterial branch points and near the circle of Willis. So these little balloon-like aneurysms have a neck connected to the parent vessel, and a dome that's, of course, under increasingly pressure, increasing amounts of pressure, and becoming increasingly thin and prone to rupture. So the most common locations are here, an aneurysm of the anterior communicating artery, here an aneurysm of the posterior communicating arteries, and finally, less commonly, you can have an aneurysm of the middle cerebral artery. That's what they're showing over here. You can have aneurysms in other locations, but the branch points are common locations, and these happen to sort of be the three most common. Now, unlike the other meninges and the brain itself, the dura is innervated and pain sensitive. And so it's this dural innervation that underlies the pain associated with meningitis, which is inflammation of the subarachnoid space. And that's what you can see in this image. This is an autopsy picture, presumably. The dura has been reflected, and you can see the purulent matter or pus that's associated with inflammation of the meninges that you can see when we remove the dura. And so the dural innervation underlies the pain of meningitis and the dural deformation that people experience due to increases in intracranial pressure. So when people have this horrific headache associated with hemorrhage, like subarachnoid hemorrhage particularly, or epidural hematoma, where it's arterial bleeding and the dura is becoming deformed, it's dural innervation that is what's creating that pain signal. The false cerebri, for example, and parts of the dura that are anterior and middle in the cranial fossa are innervated by the trigeminal nerve, whereas the tentorium cerebelli, and parts of the posterior dura are innervated by glossopharyngeal and vagal nerves. So those are the cranial nerves that equip the dura with pain sensitivity. That's really important when the dura is deformed by things like hematoma.